as I wish you all a good evening once again. It is the Mumbai model that is the talk of the town. That has drastically helped the numbers in Mumbai go down when it comes to the spread of the infection or containing the surge in COVID cases. Now, why is it that this model has been so successful? Why is it that the Supreme Court has praised this model and other states are wanting to replicate it? What are the key strategies in place? To help us understand this, joining us are two very special guests this evening. I'd like to introduce Dr. Zahir Virani. He's a nephrologist, DNV Nephrology, member of the Maharashtra COVID Task Force. He's joining us live from Mumbai. And also Dr. Sanjeev Bagai. He is the chairman of Nephron Clinic. He's joining us live from Delhi. Very good evening to you, doctors. And if I could go to Dr. Sanjeev Bagai first. Now, doctor, of course, it is the role of the healthcare workers, the doctors, the nurses that is primarily in place. But I'd also like to mention the BMC, because the plan of the BMC commissioner was to decentralize the fight. And he said that there are three strategies. One is to reduce the panic. Second is to set up war rooms for quick response time. And the third is to have adequate infrastructure. How has all this helped aid doctors to treat patients better?
Good evening. Delhi, much like Bombay, is a vast ocean of humanity. Delhi's population, including the migrant population, is anywhere between 20 and 22 million and counting. This is something which I've written on Twitter and also tagged the Honorable Chief Minister of Delhi and other officers in Delhi. Delhi cannot be managed the way it is being managed. There are 10 points, and I'll just briefly mention them, and then if time permitting, we can discuss it more in detail. Delhi has to be divided and subdivided in a gridlock formation. The gridlock formation is divide Delhi into 20 zones. There are 2 nodal officers per zone, 1 officer per hospital of more than 100 beds. These people who are one-point contact will look after the bed allocation, the human resources, ambulance services, cremation, recording death, recording new admissions, oxygen supply, supply chain management, and they report to the war room on a real-time digital graph. Point number 2, it should be a separate vertical of home triage. We have to decompress and decongest the bulging hospitals because they can't take that much load. 85 to 90% of the cases can be very well managed at home. Point number 3, we need data monitoring in a predictive format through an AI model so that we know on a week-on-week, day-on-day basis what your requirement of your essential supplies would be in the next few days. Point number 4, these nodal officers are in charge also of testing and genomic sequence. At the moment, within Delhi environment, we don't know what the genomic sequence data is, and including the contact tracing. 6 is they are also in charge of allocating the adequate amount of centers for the vaccination drive, involving the RWAs and other agencies, setting up support groups. A lot of families need support, not only financial, structural, physical, moral, psychological support. Point number 8 is we need RWA volunteers who can be your arms and eyes and ears on the ground in different areas. Point number 9, we have to stop for at least 7 to 14 days interstate travel in and out of Delhi. If the borders are going to be porous, you'll be leaking infection left, right, and center, coming in and going out. And point number 10, most important, we need a healthcare worker for doctors and nursing staff as frontline workers as a helpline. A lot of doctors are under a lot of psychological stress. We are not looking after the mental health of the workforce. A lot of the doctors also have a lot of issues of anxiety, panic, fear. There is a perpetual fear that we ourselves can get infected. There is no redressal for that. I think that especially the junior staff who's suddenly seeing so much of work, so much of death, so much of blood, so much of tears, so much of stress. I think doctors also are human beings. They have to be looked after, because if they fall unwell or they go off duty, we'll be left for nowhere. So these are the 10 points. We have to treat it as a war. We have to report to a war zone. We have to divide it in a grid formation, much like in a military.
Right, Dr. Bagai, I will touch upon some points that you've made, but I also want to bring in Dr. Virani. He's also a member of the Maharashtra Task Force. Dr. Virani, your inputs on why you think the Mumbai model has been successful. And I also want to touch upon another point that Dr. Bagai said when he spoke about fear. Now, the BMC has said that instead of having a central war room, they have said that the COVID testing laboratories should not report the results directly to the patients and straight away send it to the war room. So this has greatly helped in reducing panic. How do you think all these factors have helped?
So, good evening. First of all, I'd like to say that our BMC Commissioner, Municipal Commissioner, Mr. Chalal, has done a wonderful job. Obviously, it takes a lot of political will to get the job done. And so it's a team effort. It's the political will, the Municipal Commissioner and the doctors on board who've been advising and working as a team. It's a hub and spoke model. We do have a war room. And Bombay, like Dr. Bagai was saying, has actually been divided according to wards. So we have A, B, C, D, E, F, G. And each ward has somebody who has taken charge from the BMC. Now, what happens is that it becomes very easy to get admission, to get into a corona care center, or even to isolate at home when it's a ward-wise distribution. So once your report is positive, the doctors who have tied up with the BMC get in touch with you. They assess you, and on the basis of that, it is decided whether you need to go into a corona care center or you need to go to a tertiary care hospital. The other thing I'd like to mention here is that it is a public-private partnership. So even the private hospitals, 80% of the beds are allotted through the BMC. And therefore, this shortage of beds was taken care of. The patient doesn't have to go from hospital to hospital looking for a bed. Whichever tertiary care hospital falls in its ward, if he turns positive and he needs a tertiary care hospital, the BMC has been very kind to give that person a bed there, and it has made it very streamlined instead of having relatives running here and there.
Oh yes, that's a very important point you've made, and I want to take that to Dr. Bagai, because Dr. Bagai, this is genuinely the problem in Delhi. A patient and his family has to run from pillar to post to get a hospital bed, whereas that problem has been fixed in the Mumbai model. The BMC is helping the patient to get a bed, what is the severity of the patient, and what is the kind of bed he needs, whether it is an ICU bed or a normal oxygen bed. And another thing that you mentioned, that how the medical staff needs to be taken care of. Now, as a part of this Mumbai model, the medical staff is being provided with a stipend of 50,000 rupees per month plus a hotel accommodation within their ward, which is at walking distance, and they literally have budgets for 900 doctors, 600 nurses who can accompany the ambulances in each ward. So they are also taking care of the medical staff, exactly that you mentioned.
Yeah, so whatever you have mentioned and whatever I have mentioned and whatever my colleague has mentioned from Bombay, that's not occurring in Delhi on the ground. So just allow me a minute. A patient falls unwell, the saturation falls suddenly late evening, early morning hours. The person doesn't know which hospital has a bed availability. If he goes there, it's showing something on the app, but in reality, the bed is not there. He goes to another hospital. Then the Twitter is in action, then the WhatsApps are in action, and all other social platforms are in action. That's not the way to treat a critical patient. Your time to treat a critical patient who's suffering from hypoxia and dipping very quickly with multi-organ involvement is just half an hour to 45 minutes. Sooner he reaches the hospital, lesser will be the complications and better will be the survival. Now, what we need is a more coordinated, more cohesive action. I have written on this almost a couple of weeks back. It's not happening. The people are stranded, actually, not knowing what next step to take. If it is divided into this gridlock formation, you know which are the hospitals coming in your zone. You have a one-point contact to contact. You know where to go. It is that person's responsibility to make sure that the person gets a bed, be it an ICU bed or otherwise. The second important point is home triage. We have to have a systematic formation in which patient can be screened at home. Mild and moderate patients, all of them do not need to reach the hospital. They can easily have a quick triage at home. A triage word means they can get an initial assessment, clinical assessment at home. If the patient is stable, then they don't have to go to the hospital. We need it more coordinated at a granular level. If you want Delhi not to burst with numbers, we have to do it. We have to do it now.
Right. And like Dr. Virani, you mentioned that it is really the collaborated effort of the state government and the BMC. And yes, they've had to escalate the budgets because when the BMC commissioner had taken over last year, there were some horrific videos that were emerging, literally of dead bodies wrapped in garbage polythenes and kept in government hospital wards. And at that time when he took over, reports suggest that there was literally a shortage of everything from medical equipment to sanitizers, oxygen masks, disposable bed sheets, and you name the things that were required. But yes, they have taken that decision. They've escalated the budgets. They understand that this is a pandemic and they need to take everything in control. And so they work towards it like that.
See, the other thing I would like to mention here is that any patient who does not require oxygen should be at home. He should not be occupying a bed either in a corona care center or in a tertiary care hospital. There is a 6-minute walk test, which is very easy. There are multiple videos on YouTube. Your family physician can explain to you. If you do not desaturate after walking for 6 minutes, you do not need to be in a hospital. There is a lot of community help and a lot of family physicians who have taken the onus on themselves in Bombay, who are actually going and visiting corona patients at home, obviously in full PPE, and taking care of them at home. This has also basically reduced the burden on corona care centers and tertiary care hospitals.
Right. But then again, Dr. Virani, it is the BMC also taking that decision for the patient basis how his condition is and doctors who are helping out with it. So it is really that structure that they've set up. Dr. Bagai, I want to come to you because Bengaluru is now wanting to replicate the same model, and they want to have a decentralized approach with debtor communities, what they call decentralized triage and emergency response. They want to have that in 198 wards to basically also reduce the turnaround time. You think other states wanting to implicate the same model will deliver results, and that includes Delhi also? Please share your view.
Yeah, there are a lot of good intellect people in India. There's a tremendous amount of intellect within the medical community, between the IAS community. If a model has worked well, that model belongs to no individual state. That model actually belongs to India. So if a particular thing is working well because it has been structured well, it has been implemented at a granular micro level and it is functioning smoothly, why not do it in other parts, especially the major metros? Now, if this particular thing, I think my colleague Doc and me are speaking the same language. We should be doing this. We should do it in Delhi. We should do it in Calcutta, Bangalore, Hyderabad, Chennai, Kochi, in Gujarat, in major towns. It's an easy thing to do. Why should the patient be in any confusion and anxiety whether the person is going to get a bed? Point number 2, does a patient know he needs a bed at all or not? Point number 3, if he reaches the hospital, why should he be denied a bed? I think that's criminal. Why should a hospital have less oxygen? I mean, these are things where the nodal officers come in. The hospitals should not be calling multiple agencies to get the supplies. It is these nodal officers, the SDMs of that area, which coordinated it for the hospital. Free the doctor to see the clinical load. Don't involve the doctors in lower administrative jobs in following up things which otherwise routinely should have reached the hospital.
Oh yes, absolutely. And this is where the BMC has taken over. Dr. Virani, they say that it is a result of careful planning, quick action to fix emerging situations, a powerful feedback loop, smart information dissemination, and the willingness to spend money to be able to deal with a crisis of this scale. Help our viewers understand, especially outside of Mumbai, of how this model is working on the ground.
So actually, if you go through some of the interviews given by the BMC commissioner and his associates, they actually had planned for this almost at the mid last year or at the end of last year, where they had actually put up oxygen tanks in all 16 or 18 private hospitals. And they had kept those cylinders as backup. So they had prepared in the last year itself for this sort of oxygen deficiency, and they had kept everything in reserve. So the backup was there from the beginning. There was no panic where we were running short of oxygen. So this oxygen, and secondly, there was a nice guideline which was set up on how much oxygen is required per person, which was actually given through the task force to various hospitals. So as far as medical professionals were concerned, you were told that you did not have every patient at 100% saturation, and even a saturation of 93, 94 could be used. There were also certain devices which were there, which are known as high flow nasal oxygen, HFNO or HFNC, which use up a lot of oxygen. So those devices were minimized and were restricted to absolutely necessary cases. So it was rationalizing the use of oxygen, being ready and prepared from last year, and making sure there was no panic and beds were allotted properly to everybody.
And Dr. Bagai, if I can come back to you, again, certain points of the Mumbai model that they have literally broken it down at every level. Now, 17th April is when 168 patients were shifted overnight to hospitals and there was adequate oxygen. They managed adequate amounts of remdesivir and other medicines. There was not a single death that was reported when they were receiving utmost load. And not just this, they've also managed to refurbish and requisition 800 SUVs, which they've created into ambulances with the driver's area separated with a partition glass, and they've asked Uber to help track these ambulances. So just the level to which they've broken it down to be able to simplify every step so that help is received faster.
In these kind of situations, very much like in medicine, when you have critical patients or critical emergencies, it's the famous 5 Ps. And the famous 5 Ps state, proper planning prevents poor performance. If a particular model is working well on the ground, it is easy to pick up the good points, implement them over here. Like I said, there is no egos hurt. We are trying to save lives. We need genomic testing. We are not doing enough of genomic testing. We need more amount of routine testing of RT-PCRs in Delhi. The contact tracing. We need to seal the borders. Like in Delhi borders, still we have the farmer strikes going on. They are a volcano of infection. And they are going to go in deep into the interior of Haryana, Punjab, and back into Delhi and infect everyone. So what we need is now a very cohesive force. Otherwise, it's not the question of lockdown. Otherwise, this present second wave will not see a ebb. If you leave this bushfire burning anywhere in the part in and around Delhi, NCR, or in northern area, it will spread again. We need a very cohesive, integrated, seamlessly integrated strategy to control this. And my request to everyone is, whoever are the policymakers, whoever are the people who are in charge of taking the decisions, have a plan in place so that the patients' lives are saved. Break it down at a granular level. You cannot do it at a center, top heavy. You have to bring it down at the last mile cover so that the last patient who's suffering in pain doesn't go from pillar to post. There are a lot of families still who are approaching for blood, for plasma, for a simple question of a bed, non-availability of an ICU bed, availability of an ambulance. There are some ambulances who are charging more than 5,000, 10,000 rupees for just 3 or 4 kilometer journey. All these things are causing a lot of distress and a lot of anxiety in people's mind.
Very true, Dr. Bagai. It's very important that that message goes out, and really authorities, corporations and the government that work in tandem with each other. As it is time for us to wrap this discussion, Dr. Virani, I just want one last question from you, that the BMC is also preparing for the third wave of the pandemic. How is that working out?
So the only way to prevent the third wave is to vaccinate. We need to get, now we got to move ahead with light speed with vaccination. We have to have COVID appropriate behavior. Just because you have had COVID once in the past or you're vaccinated, you shouldn't forget to wear your mask, hand hygiene, and we should just remove vaccine hesitancy. How we do that, we educate people, we get people who have been vaccinated or who have suffered from COVID to give their experiences. But the only way forward right now to prevent the third wave is to vaccinate. We got to get in the vaccine, whether it be Covishield, Covaxin, Moderna, Pfizer, Sputnik, whatever we get our hands on, we just have to vaccinate. And remember now, we are seeing cases in children as well. So as soon as we are done with the vaccination of above 18, we should look at vaccinating our children as well.
Very true. On that note, Dr. Virani and Dr. Bagai, many thanks for sharing your inputs this evening. Most importantly, it is necessary that the municipal corporations, the respective state governments take the message that doctors are trying to put out at this point, because given the scale of the pandemic, it is not just in the hands of the medical fraternity, but a lot of outside help on the ground that is also required when it comes to coordination. We'll leave it at that. A very big thank you once again.
Thank you.
Thank you. God bless.